Well, good morning, all of you, and good afternoon and good evening to all others who are joining from the rest part of the world. Today, our guest speaker for the day is Dr. Reena Nair from Kolkata, and she's going to lecture us on bispecific antibodies in lymphoma. This webinar is brought to by Mumbai Hematology Group, supported by Roche, Natco Oncology, Lucien Life Sciences, and Nirvin Life Sciences, and very well managed by Perfect Square. I thank Team Roche, Natco, Lucien, and Nirvin, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Priyanka Srivastava from Karamsad, our guest speaker for the day, Dr. Reena Nair from Kolkata, all our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for sparing the Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 17th of August 2024, from 7 p.m. Indian Standard Time and 9:30 a.m. Eastern Time, your Dr. Rajshekhar Chakraborty from Colombia speaking to us on bispecifics for treating multiple myeloma. And the following day, that is Sunday, 18th of August 2024, from 11:30 a.m. Indian Standard Time and 8 a.m. Netherlands Time, your Dr. Rick Kapoor from Amsterdam, Netherlands, speaking to us on basics and applied aspects of immunobiology of ITP. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Aditya Jandial from Tata Memorial Hospital, Mulanpur, Punjab. Dr. Akanksha Garg from Zydus Hospitals and Zydus Cancer Center, Ahmedabad. Dr. Anil Singhvi from CHL Hospital, Dr. Ashish Dixit from Manipal Hospital, Bengaluru. Colonel Dr. Ashok Meshram from Command Hospital, Kolkata. Dr. Bharat Parikh from HOC Vedanta, Ahmedabad. Dr. Chirag Shah from Apollo Hospitals International, Ahmedabad. Dr. D.S.K. Sahitya from Medicover Hospitals, Vizag. Dr. Deep Gala from SGPJ, Lucknow. Dr. Fahima Hassan from United Institute of Medical Sciences, Prayagraj. Dr. Gopinathan M. from MGM Healthcare, Chennai. Dr. Khushbu Jain from Medicover Hospital, Aurangabad. Dr. Kripa Bajaj from KIMS Hospital, Hyderabad. Dr. Krishna Kumar Ratnam from Meenakshi Mission Hospital and Research Center, Madurai. Dr. Krishna Ratnam Kannan from Sundaram Medical Foundation, Chennai. Dr. Lalit Mohan Sarma from Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. Professor Dr. M. Joseph John from Christian Medical College, Ludhiana. Dr. from Comprehensive Cancer Center, Manipal Hospital, Bengaluru. Dr. Mona Vijayan from SGPJ, Lucknow. Dr. Nadim Shoket from American Oncology Institute, Jammu and Kashmir. Dr. Narendra Kumar Chaudhary from AIMS, Bhopal. Dr. Nidhi Sharma from SMS Medical College, Jaipur. Dr. R. Prasanna from Cancure Cancer Center, Tamil Nadu. Dr. Rajan Yadav from GCRI and BJMC, Ahmedabad. Dr. Ramesh Balasubramanian from Meenakshi Mission Hospital and Research Center, Madurai. Dr. Ravi Kiran Bonanthia from Hassan Institute of Medical Sciences, Hassan, Karnataka. Dr. Rizwan Akhtar from SGPJ, Lucknow. Dr. Roshni Pandey from Mahakoshal Hospital, Jabalpur. Dr. Sandeep Shah from Gujarat Cancer and Research Institute, Ahmedabad. Dr. Sanket Shah from HOC Vedanta, Ahmedabad. Dr. Satish Kumar A. from Manipal Hospital, Yashwantpur, Bengaluru. Dr. Shailesh Lavana from Kailash Cancer Hospital Research Center, Goraj, Vadodara. Dr. Shyam Agrawal from Navodaya Cancer Center and Research Center, Indrapuri, Bhopal. Dr. Siddesh Kalantari from Blood Care Hematology Clinic, Nashik. Dr. Sudarshan Pandit from Ashoka Medicover Hospital, Nashik. Dr. Sushil Selvarajan from Christian Medical College, Vellore. Dr. Tushar Pandey from IMS and Some Hospital, Bhubaneswar. Dr. Upendra Sharma from Bhagwan Mahavir Cancer Hospital, Jaipur. Dr. Vikas Talreja from Regency Hospital, Kanpur. Dr. Vinay Bohra from CHL CBCC Cancer Center, Indore. Dr. Yashwant Kashyap from All India Institute of Medical Sciences, Raipur. Dr. Yimo from North Okalapa General and Teaching Hospital, Yagod, Myanmar. Now it's time to introduce our special guest and chief guest for the day. We have with us my friend, Dr. Priyanka Srivastava, MD, DNB in Medical Oncology. Dr. Priyanka Srivastava is MD, DNB in Medical Oncology, Fellow, Medical Oncology, PMCC, Canada, Consultant Medical Oncologist at MS Patel Cancer Center, Shri Krishna Hospital, Bhaikaka University, Karamsad, Gujarat. Dr. Priyanka Srivastava is a medical oncologist and hemato-oncologist working at MS Patel Cancer Center, Karamsad, Gujarat. She pursued MBBS from Medical College, Vadodara, Gujarat, and was awarded gold medals from MS University. She has done MD in internal medicine from Baroda Medical College, followed by DNB in medical oncology from Indraprasth Apollo Hospitals, New Delhi. She has also done a fellowship in medical oncology from Princess Margaret Cancer Center, University of Toronto, Canada. At present, she is working as a consultant medical oncologist and hemato-oncologist at MS Patel Cancer Center, which is a rural-based tertiary referral center. It is a part of National Cancer Grid and hospital-based cancer registry program of ICMR. She's a mentor for DNB Medical Oncology program at her institute. She has several publications in peer-reviewed journals. She is also the editor for the gynecology section of Indian Journal of Medical and Pediatric Oncology. It's my privilege to welcome Dr. Priyanka Srivastava to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Priyanka Srivastava.
Good morning, everyone. Thank you, Dr. Amit, for the kind introduction. I thank Dr. M.B. Agarwal, sir, for giving us this opportunity, and Maharashtra Hematology Group for bringing this webinar so close to us. It's been a pleasure and honor to be associated with Maharashtra Hematology Group, and this webinars have changed our life. We have continued to be a student for the life, and this webinar on every Sunday afternoon bring us a wealth of knowledge to our doorstep, where we get to hear from the esteemed scientists and researchers every Sunday. And I highly encourage the students to be part of this group, part of the group of Maharashtra Hematology Group, as well as attend this webinar, because we get to hear from experts and the experts' opinion, the recent advances, which may be very far from a country like India. For example, today's topic, like Reena ma'am, is the one of the authority in hemato-oncology group, and we are going to listen to her about the bispecifics, and it will be a wealth of knowledge to attend, and I look forward to it. And I wish luck to my all students, and thank you, and thank you, Amit, again, and good day to all my colleagues. I think we should not waste another minute in introductions and just get to the listening to Reena ma'am. Thank you.
Thank you, Dr. Priyanka, for that wonderful words of wisdom and accepting our invitation to join as our chief guest for the day. Thank you so much. I share the screen once again. Now it's a time to introduce our guest speaker for the day. We have with us Dr. Reena Nair ma'am from Kolkata. Dr. Reena Nair ma'am is very senior consultant clinical hematologist, head Department of Medical Oncology at Tata Medical Center, Kolkata. She did her MBBS and MD in internal medicine from Goa Medical College under Bombay University way back in 1979 to 1988, followed by residency 1988 to 89 and fellowship from 1991 to 1994 in medical oncology at Tata Memorial Hospital, Mumbai. She was also the faculty lecturer to professor at Department of Medical Oncology at Tata Memorial Hospital way back from 1994 to 2012. She has been the principal investigator in 35 clinical trials, which is investigator-initiated as well as industry-sponsored clinical trials. She has been the executive committee member and faculty at Australia and Asia Pacific Clinical Oncology Research Development, that is ACCORD, workshop from 2010 to 2018. She has been the international scientific advisor to the Lancet Oncology from 2020 to 2022. She has been the guest editor of Lymphoma Outcomes from India for Frontiers in Oncology from 2021 to 2022. She has been the editor, Management of Hematological Malignancies in the LICS for Frontiers in Oncology from 2022 to 2023. She has published over 125 papers and 15 book chapters. Her current interest is management of hematological malignancies with special interest in lymphomas. She has been the founding member of the National Myeloma Group, that is IMAGE, from 2017 till date. She has been the principal investigator of the OncoCollect Lymphoma Registry from 2018 till date, founding member of the Immuno-Oncology Society of India from 2019 till date. She is also the founding member of the Women for Oncology India Forum from 2021 till date. Her recent awards and honors include: she has been the inspiring oncologist 2020 on Doctors Day Conclave Economic Times, Aparajita Saluting Womanhood 2021 10th Annual Awards, Indian Society of Medical and Pediatric Oncology Oration 2022. And today she is with us and she's going to lecture us on bispecific antibodies in lymphoma. Well, thank you so much. I stop over here. Over to you, Dr. Rina ma'am.
So thank you very much for organizing continuous medical education for all of us, just like we heard. And I'll share my screen and then we will start the talk for today. At the outset, let me say that this talk is a little tough for me also because I don't have too much experience in these drugs. So it's going to be more of actually giving you theory from the articles that are around. Can you see my screen?
Yes, ma'am. Full screen mode, ma'am, please.
Now?
Yes, perfect.
So I'll speak on bispecific antibodies in lymphoma as the topic is today, and see if I can put in a little flavor of what we have been able to understand of these drugs in our own little experience. So these are my disclosures, and some of the slides, of course, are borrowed from Roche and Ida as I present. We have novel options available for Hodgkin's lymphoma. And this is a very highly curable disease now. Chemotherapy by itself cured about 80 to 90% of the patients. After the advent of brentuximab and checkpoint inhibitors, more or less the outcomes have been excellent. And so not much work is available in bispecifics except to say that there are clinical trials on for anti-CD30 along with NK T cell receptor antigens, which is the CD16. But this is all in early trials and we don't have much information on it. And the reason is if you look at Hodgkin's lymphoma, what has happened with the frontline treatment is almost 90% are curable. For those who get this disease back with conventional salvage chemotherapies, we saw good overall responses, but the complete response rates were somewhere in the range of 20%, and at best, in very small series, went up to 40%. However, when the novel combinations came up, and that is brentuximab and nivolumab, either with chemotherapy or together, we suddenly see that there is a response rate which is PET negative almost in 60 to 80% of the patients. And if these patients undergo high-dose chemotherapy and stem cell transplant, a large number of them are cured. And if we look at therapy for relapsed refractory Hodgkin's lymphoma with the two new drugs together, we find that the 3-year progression-free survival for relapsed refractory patients is 77% overall and 91% for those who undergo stem cell transplant. If we look at the outcomes at 3 years for patients who have relapsed Hodgkin's lymphoma, it is 90%. And even for those who have primary refractory, in the earlier years, we could hardly salvage any of these patients. Today, we find that 61% of these patients are alive and well at the end of 3 years. And so even in relapsed refractory Hodgkin's lymphoma, the drugs that are available have a cure rate of almost 93% or an overall survival of almost 93% at 3 years. And this is something which was pretty unimaginable. Things have not been the same. And so we keep looking for new drugs in lymphomas, that is non-Hodgkin's lymphomas, both for the aggressive lymphomas as well as for the indolent lymphomas. We know that upfront treatment gives us a progression-free survival at 2 years of less than 70%, which means over 30% of these patients will relapse. And unlike for Hodgkin's lymphoma, that we have drugs which give us great outcomes, if we look at what is available in literature from standard chemotherapy point, we hardly have outcomes of 20 to 30%, whatever be the salvage regimen that we use before high-dose chemotherapy and auto transplant. If at all there was some better outcomes, it was for patients who had not received rituximab in the prior treatment, but that is the kind of patients we don't see anymore. There is hope now with phase 2 and phase 3 POLA-R-ICE trials as a bridge to transplant, and these results are still to come. So we definitely need a paradigm shift. We cannot continue to have chemoimmunotherapy as a second line therapy, and better drugs have come in use for the last 5 to 10 years. CAR T cell is something that everybody is familiar and is and has based maximum hope on. We have other monoclonal antibodies such as tafasitamab. We have the ADCs, which is polatuzumab, which is an experience which most of us have had. And we also have the emerging bispecifics in non-Hodgkin's lymphoma. Just a slide about CAR T because we will have arguments on which is better treatment at the end of the talk. So just to say that it was in 2017 that it became approved for relapsed refractory aggressive B-cell lymphomas. It demonstrated remarkable efficacy, but there are significant challenges that remain with CAR T therapy. Besides developing the CARs, we also have patients who eventually relapse and become refractory to CARs. Toxicity was a major limiting factor in the management of patients with CAR T cell therapy. And CRS and ICANS is something we will discuss in a little more details because this is common toxicity for CARs and bispecific antibodies. CARs have definitely changed the paradigm of treatment for patients who relapse or who are refractory and have become the preferred second-line therapy because the outcomes that they give are far better than what we get with salvage chemotherapy followed by high-dose chemotherapy. So we have a lot of drugs. We need to know how to sequence them for aggressive management of DLBCL, especially the resistant and the relapse. But for today, we will stick to the CD20 bispecific antibodies at the extreme right of this slide. So we've used monoclonal antibodies for a long time. They bind to the same antigen fragment. But the monoclonal antibodies cannot cure lymphomas because they do not activate T cell lymphocytes, which are the active part of tumor destruction. And that's how the BiTEs or the bispecific antibodies came up because they have an antigen which binds to the receptor that activates cytotoxic cells and a second antigen which is expressed, which binds to the tumor cells. With that, they bring about killing of the tumor cells. The mechanisms are complex of these BiTEs, but basically they activate T cells directly. They help the activated T cells express high levels of CD69 and 25, which promotes proliferation of T cells. And when there is exhaustion of T cells, BiTEs actually strategize to induce these T cells also through very complex mechanisms, which are mentioned at the bottom of this slide. So now we have BiTEs that engage the effector cells as well as the malignant cells. And the BiTEs that are used commonly in lymphomas are the CD20 and the CD3 BiTEs. And of course, like I said, we will discuss a little bit about cytokine release and neurotoxicity, which are perhaps the side effects which increase the risk of treatment with these drugs. Presently, the bispecific antibodies that are available for lymphomas include blinatumomab, which was the first BiTE, which is CD19 and CD3 conjugate. The remaining which we use for lymphomas are all CD20 and CD3 BiTEs, whether it is mosunetuzumab, glofitamab, odronextamab, or epcoritamab. All of these are monovalent CD20 except glofitamab, which has a bivalent CD20 and is supposedly a little more it's a little more tested and tried, I would say. I can't say it is better than the other BiTEs that are available. So blinatumomab, no doubt, was the first to be used in aggressive lymphomas. But for now, we find its potential applications are all in precursor B-ALL. And it was initially used to treat relapsed refractory B-ALL. Now it is used upfront to treat patients who are MRD positive to achieve better responses. It is used in induction and consolidation of BALL and in maintenance post allogenic stem cell transplant. It is also being used along with other tyrosine kinase inhibitors in pH positive ALL with the hope to give treatments which are chemotherapy free and have only targeted therapies acting on the disease in order to reduce the toxicity of the older drugs that we have used so far. So the initial trials were with glofitamab, which I said is CD20 and CD3 antibody uh, comprising molecule. We normally give obinutuzumab as a priming drug in order to occupy the CD20 surface on lymphoma cells and deplete the peripheral B cells with the idea of reducing the cytokine release syndrome. And that is one of the reasons why these drugs have become easier to give, because we have strategies to mitigate the CRS, which can be pretty toxic sometimes. Glofitamab is administered IV and it is given in a step-up dosing schedule. And this also mitigates the amount of CRS that we see with the bispecific antibodies, unlike the CARs. More recently, there are trials of patients who are over 60 years of age with the idea to see whether adding glofitamab to CHOP will actually improve the results that we see in elderly patients. And also there are trials actually to see if only 2 or 3 monoclonal antibodies put together along with BiTEs will replace the old chemotherapy. So typically we would all have seen a patient like this. This is a 59-year-old patient who presented to us in 2014 with follicular lymphoma, grade 1, stage 4A. He received 6 cycles of bendamustine rituximab and was on rituximab maintenance when he had a fall and a fracture femur for which he was immobilized, later underwent replacement, but the pain persisted. And at that time, when a repeat X-ray was done, it showed a lytic lesion, and the HPR from the lytic lesion showed a transformed DLBCL. So going by conventional therapies, he underwent salvage chemotherapy, beam conditioning, along with auto stem cell transplant, and was well from 2016 to 2022. And then he was 67 years and he developed prostatic symptoms for which he underwent a TURP. The HPR at that time suggested that the prostate was enlarged, involved with non-Hodgkin's lymphoma. And the PET after this procedure showed extensive disease both above and below the diaphragm, with not only prostate but multiple skeletal system lesions as well as a pathological fracture. We again started with what we have, with thinking that he had 6 years of disease-free interval in between, and he would respond to the regular chemotherapy drugs. He achieved a partial response, became mobile, but at the end of 6 cycles, the disease was still present, and that's when we kind of looked for something which would be different from the regular chemotherapy drugs. And through a compassionate access program, we did get glofitamab. We did the priming with obinutuzumab, and then we gave him glofitamab. He was in complete metabolic response after the 3rd cycle, continued till the 10th cycle, and continues to remain in response thereafter. So these are the comparisons of the drugs that are available to us and the kind of responses we have seen in early phase trials in literature. The last column is glofitamab. And if we look at the dosing patterns, it is step-up dosing, which, like I said, mitigates CRS. The overall responses are fair, and the complete responses are also reasonably good for patients who are refractory and resistant to treatment otherwise. And both for indolent and for aggressive lymphomas, we find almost a 50% complete response rates. The median progression-free survivals are not very impressive. And so we know that something more has to be done after we have put these patients surgery for CAR T or other therapies is something that can be discussed. The cytokine release syndrome is there in a large number of patients, that is, all grades is over 60%. But if we look at grade 3 and 4, it is less than 5%. And ICANS have not been reported by this drug, and perhaps it is the strategy which we use to give this drug. If we look at mosunetuzumab, it has been used again for both DLBCL and indolent lymphomas. The responses, overall responses for indolent lymphomas is better than for aggressive lymphomas. And similarly, the CR is better for indolent lymphomas as compared to the aggressive lymphomas. It appears that about 82% of indolent lymphomas have ongoing responses at 26 months, as compared to lesser time for patients who have aggressive lymphomas, which is about 16 months. Again, if we look at the CRS and ICANS, it is no different from what it is for glofitamab. If we come to the first column, which is the first bispecific antibody, that is blinatumomab, which has been used perhaps earliest, the response rates in the initial phase 1 trial were pretty impressive at over 60 and a CR rate of 36%, but this did not hold in the phase 2 trials for DLBCLs. And again, if you look at the two bottommost rows, the CRS and the ICANS is pretty high for Blina, and the grade 3 and above CRS and ICANS is reported above 20%. And so this drug becomes a little difficult to give, not only because of these toxicities, but because it has a very short half-life. And you have to give it continuously for about 4 weeks, which means admitted patients in the ward and continuous infusion over 4 weeks with a gap of 2 weeks followed by the next cycle, which would be the same. So there is differences in the toxicities of CD19 versus CD20 bites. And the most common toxicity that we encounter, like for all drugs that we deal with, are cytopenias. These are usually transient. Supportive measures, including transfusion of blood products, and the use of growth factor mitigates, and most patients are able to take their next treatments on time. A real complication of these drugs is infection, and the etiology is multifactorial. It is likely because there is a lot of immunosuppression that happens due to immune depletion and subsequent hypogammaglobulinemia. And so one has to remember that we not only need to use antivirals and antifungals as prophylaxis during the time we treat these patients, but we also need to consider prophylactic or therapeutic treatments with intravenous immunoglobulins, and that obviously increases the cost of therapy because of frequent hospitalizations and the IVIG. The real toxicities are cytokine release and the neurotoxicity of bispecifics, just as the CARs. The reason for cytokine release syndrome is the activated T cells, as a result of which pro-inflammatory cytokines are released. And in the early grades, it may cause fever, which is constitutional symptoms. But as it progresses, it can cause life-threatening hypotensions and hypoxia. And so one has to be very aware of this toxicity and be prepared with the drugs rather than go out to get these drugs when a problem happens. Supportive care is initially with antipyretics, fluids, and if that doesn't work, vasopressors and TOSI has to be given to these patients to mitigate the cytokine release syndrome. Neurotoxicity is another toxicity which we need to learn much more about when we use these drugs. In the initial period, it may be confusion, ataxia, aphasia, tremors, and eventually seizures. The reason for neurotoxicity may be direct action, or it may be due to the cytokine release. It is more common associated with blina because there is expression of CD19 on the neural cells. And this is one of the reasons why we see this toxicity much more commonly with blina rather than the other CD20, CD3 bites. Supportive care is the same with steroids, anti-epileptics, and you may need to see to these patients. These are two charts which I would suggest for everybody doing CAR-T and bispecific therapies to have available easily in your wards for fellows. One has to know that fever is associated with cytokine release syndrome as with other infections. But if fever increases and the patients develop hypotension, which is not which requires vasopressors, then one has to work much more closely, monitor these patients much more closely. And if they develop hypoxia, they will require not only regular oxygen, but also they may require positive pressure oxygen. So one has to be ready for everything right up to ventilation in these patients. And it is graded depending on the grade, we take a decision about how much treatment is required, vasopressors not required, whether a single vasopressor is enough, a combination is required, and ventilation is required. We have ICANS or the neurotoxicity, and this is another chart that needs to be available easily to score the patients if they have any confusion or they have any lethargy or they are sleeping too much. The ICE scoring is shown at the bottom of the chart, and it is basically to have an idea whether the patient is well oriented in time, place, or they are able to kind of name objects clearly. You give them 3 objects and they should name them, or their scores are going down, which means their CNS is actually getting more and more affected. If they can only write standard small sentences, follow simple commands, or their attention is reduced when they count backward. Coming back to our patient, we did go into complete metabolic response. Until date, he continues to be in complete metabolic response after a 4th line of therapy. But post 6 cycles, he was admitted with respiratory virus infection. Post his 9th cycle, he had a lung infection which needed a bronchoalveolar lavage, and he had both bacterial and viral infections. At that time, since we realized that he is getting infections repeatedly, we looked at his immunoglobulin levels, which were low, and ever since then, he has been on immunoglobulin IVIG injections. Post 10th cycle, he developed SARS-CoV, and we kind of got a little worried and decided that if he is in complete metabolic response, we should actually stop therapy rather than continue till the 12th cycle and have more infections. However, we have not had much luck with his infections, and almost every 2 months, he still comes with a viral infection or a fungal infection of the lung. And so while he continues to remain in remission, it's not been easy with the post-treatment management. This is a small data of the number of patients we have got clearance for compassionate access program, which is about 15. We, at the moment, it takes time for this drug to come. So it's not as simple as off the shelf, which is one of the advantages of BITES. And we could start the drug in 10 patients out of these 15. The median age was about 57. The ECOG performance was not good for 5 patients. Most of them are de novo DLBCLs who have relapsed. There's one primary mediastinal and another 2 which were transformed lymphomas, one of the cases which I just showed you. Most of these patients present after 4 lines of therapy invariably have a lot of extranodal disease. Only one patient, which is the patient I showed you, had had a previous auto stem cell transplant after salvage chemotherapy. They've all received many lines of therapy. And these are all approximate figures because 3 patients are still on therapy. We see anemia, neutropenia, and thrombocytopenia in almost all patients. we see grade 3 infections in a large number of patients, but the CRS that we have seen has always been fever, and we haven't had patients in hypotension or requiring oxygen support. And so most of it has been grade 1, and we have not seen ICANS in this set of 7 patients who have completed treatment. The initial response was 2 CRs and 2 PRs out of 7 patients. One of the PRs progressed by the time we finished the 5th cycle. And for patients who actually had partial response or had progressive disease at the end of the 3rd cycle, we added GEMOX to their chemotherapy, but it did not seem to make any difference. So primarily the 2 patients who were in complete response continued to be in complete response at the end of 12 months of therapy. Unfortunately, we lost one to COVID and the other we salvaged from COVID, I think, because we stopped treatment early. The other drug that we have very little experience is posunatuzumab, which is again a CD20, CD30 bispecific antigen. It is a drug that again is given in a step-up dose in the first cycle on day 1, 8, 15, and then we give it every 3 weekly. The advantage of this drug over all the others is that it can be given subcutaneously, and the feeling is that the toxicity is even less in this because it is given subcutaneous. Is the time over?
No, ma'am, you can continue, ma'am. No problem.
Okay. So we have just 2 patients on this drug, and one kind of progressed at the end of 5 months. The other patient completed therapy and continues to be. We have another 2 drugs in the same category, again used for lymphomas.
Mr. Kalpesh, can you please mute yourself because we are finding difficulties here. Mr. Kalpesh?
Yeah, he's muted himself. Yeah, I thought the time was over. That's why I checked. Anyway, I'm almost through. So we have another 2 drugs not available yet to us, but they seem to have a reasonably good response rate, especially when it comes to follicular lymphomas. And again, these drugs, like the previous CD20, CD3 bispecifics, do not have very severe CRS or ICANS. So know that from the data that I have shown you that many of these patients escape the bites. And the reason why they escape bites is because there is a suppression of the T cells as we go on with the treatment. There is loss of target antigen expression, which we have commonly seen in patients who were treated with Blino for ALL. And about 8% of them, when they relapse after the bite therapy, actually are CD19 negative. And then there is a whole discussion on antigenic shift, which also makes tumors escape the bite. And so we can't just use them as single agents. And currently there are a lot of ongoing trials which are actually using these bites now in combination with previously standard regimens like R-CHOP or Pola-R-CHOP, and this is a randomized trial. We also use bites together as 2 bites given together to enhance the effect on the tumor cells. And we have a whole lot of combinations of other drugs like lenalidomide, bendamustine, GEMOX, and the regular standard therapies like DHAP and ICE. For older patients, of course, that over 80, there are trials to see if we can use the antibodies along with bites to make the therapies chemo-free for these patients. And hopefully, if they can tolerate those patients and get the same outcomes, it will be good. At the moment, things come from compassionate access, but bites are no cheaper than CAR T-cell therapies. In fact, I think CAR T-cell therapy has become much more cheaper in India now, with so many centers doing it and so many CARs available for DLBCLs. But this is one of the treatments that is available, and we will have to see how we use these. So there has For the last 2 years, if you hear any lymphoma meet, especially internationally, there is always a debate on CAR T cell versus bispecifics because both have their advantages and both have their drawbacks. This is something that I would recommend all of you who are interested in this group of drugs meta-analysis, which has just been published this week, to go through. It is a tough article to read, so I'm going to just take a few points which I have from here. But the key points to remember are that this is the first time somebody has shown that CAR T cell therapy demonstrates superior efficacy to bispecific antibodies in DLBCL treatment with a higher CR rate, and that CAR T cell therapy exhibits higher incidence of grade 3 adverse events than the bispecific antibodies. That's most of the gist of what we discussed during this particular lecture as well. They have taken 6 BITE studies, and these include most of the BITEs that are available. Remember, these are all phase 2 trials. The median age is around 60 years. The double hit lymphoma percentage is small. Most of the patients are stage 3 and 4. The median therapies these patients have received are between 2 and 3 cycles. And prior stem cell transplant has not been done in too many of these patients. The CARs, there are 10 trials they have taken. Most of the famous trials like the Zuma, the Juliet, the Transcend, and Outreach are included. Again, these are all phase 2 trials. All CARs, TISA, AXI, LISO have been used in various regimens. The number of patients in these particular trials is larger. The median age is more or less the same. The number of double hit lymphomas is not too different from the previous use of BITEs. The stage 3 and 4 relapse diseases are the largest number of patients. The median number of previous therapies were all 3 and 2. So none of these are actually trials which have been done in patients in the first line relapse setting, and prior stem cell transplant is more in numbers in these particular patients. So this meta-analysis evaluates the toxicity and the efficacy of CARs and the BITEs. They have looked at large databases. They have taken 16 studies, which I showed you, 6 in BITEs and 10s for the CARs with over 1,300 patients. The pooled CR rate for bispecifics was lower as compared to that for CAR, and this is statistically significant. The superiority persisted even when they compared patients who were CAR naive in the group of bispecific antibodies. So obviously the response to CARs is higher than that for the BITEs. In a multivariate analysis, they were able to show that CARs perhaps have a better efficacy than BITEs for double hit lymphomas. And the pooled 1-year progression-free survival gives us an idea that the patient given CARs do better than those given BITEs. This is the pooled analysis by the category for bispecific antibodies, and the lower part is for CARs, and definitely there is significant difference in the CR rates in the various studies favoring CARs to BITEs. When we look at the side effect profile, it is exactly reverse, and BITEs do far better, with CARs having grade 3 and more events in almost 20% of the patients. And so whether we look at CRS, ICANS, or infections, the BITEs do better. And the reason for this is because BITEs offer a level of dosing control. We step up the doses carefully, we have control as we give, and we can stop the treatments if patients have potential toxicities, which we can't do after we have given the CARs. And the CAR potentially, there is a prolonged exposure which causes more toxicity in the CARs. It is a similar forest plot, so to say, for patients who have adverse events, and more or less all three look alike, whether it is CRS, ICANS, or infections in these patients. So of course, the run is still on. The last word is still not there. The drawbacks of this particular meta-analysis is that it is a single study, and it is a study of trials which are in phase 2. I don't think there can be a phase 3 trial. It'll be like allogenic versus auto transplants, which we hardly ever saw phase 3 trials. But the authors feel that the kind of regression analysis and the significance of heterogeneity that they looked for is not as robust to give us the final answer. And so with that, thank you very much for your patient hearing. And if there are simple questions, I'm ready to take them. Thank you very much.
Thank you so much, ma'am, for that wonderful lecture. As always good to hear to you. And I now request all our discussants to please put the hand raise sign so that we can start our question answer session with the ma'am. So yes, first is Dr. Roshni Pandey. Dr. Roshni Pandey, your question, please.
Hi, Roshni.
Hi, how are you, ma'am?
All good.
Nice to see you in person. I wanted to know any experience with tumor flare when you all give those bispecifics.
So yes, tumor flare has been described with bispecifics. It is kind of an initial increase in the size of the tumor. We normally do our response evaluation at the end of the third cycle. So we haven't really seen, we have seen frank progressive disease. We haven't put that as tumor flare. But you have to be careful when you are giving bites, especially in the first 2 cycles. If the disease is somewhere close to an important vital organ, and this is especially true for those who have mediastinal disease, because you will have to be sure that you take care of the tumor flare, and if the size increases too much, these patients may require assisted ventilation for some time. So it is reported, it is known, but in the way we go up in small doses and go on increasing, and with priming with obinutuzumab, we haven't seen tumor flare for certain.
And, I mean, how do you assess CNS disease, or is CNS disease or a risk of CNS disease a contraindication for these bites?
So earlier, even with CARs, they used to say that they don't take patients of CNS disease on CAR therapy because they are worried that the ICANS can be far worse than what they were already seeing, which was in most of the patients, with grade 3 and 4 being in almost more than 20-25% of the patients. But more recently, with learning how to understand the management of patients who have these CNS toxicities and ICANS, I think people have become more confident, and even CARs are being offered to patients who had CNS involvement earlier and are now in remission. And there are some trials with primary CNS lymphomas who have not responded, who are now being given CARs. So bites are definitely much more easier to handle as far as CNS toxicity is concerned. All that we see is a little bit of confusion for a little while. We haven't really seen seizures or any kind of problems with the patients who have been given bites. Of course, I have to say that 7 patients and 10 patients is not a large number, and it is recommended that we are very serious about understanding these toxicities. And like I said, for the sake of the fellows, these 2 charts are important, which I think if we are treating with these drugs, we should have them handy in our wards.
And how much early should we do the vaccination before the bite?
So normally, now what has happened is over the last 4 or 5 years, we have been vaccinating our patients regularly. So otherwise, I guess, as soon as you know that you're going to take up these patients, you should, before the drug comes in, you should vaccinate them and be ready. So for us, most of these patients were on regular vaccinations, but they all require antifungal, they all require ACV as prophylaxis. And we know that anybody who goes beyond 6 cycles requires IVIG also.
And PJP prophylaxis also, no?
We are giving Septron prophylaxis.
And supposing the patients are allergic to Septron, Dapsone, then what happens to them? I mean, how do you?
So the infections that we have seen so far are all viral infections, and bacterial infections and one fungal infection. And most of these are in the same patient. And I think what happened was if we had done his IVIG levels earlier, rather than actually had 2 episodes of infection and then done it and then started from a very low level, we may have been able to prevent. So now, as a matter of policy, we do the baseline IVIG and we do it every 3 cycles. And if anybody gets an infection, we give them IVIG irrespective.
Thank you, ma'am.
Thank you, Dr. Roshni Pandey. Dr. Krishna Kanan, sir, your question, please.
Thank you so much for a wonderful educative session. It was excellent revision. I got a couple of questions. When you give prime with obinutuzumab, won't it mitigate the action of the bispecific antibody by saturating the receptors?
Yeah, that it is like a double-edged sword. If you give the whole drug, then it increases the toxicity. And the 2 reasons why we see less CRS is because we are actually giving it in a step-up dose, and we are also kind of blocking the circulating CD20 cells, which would otherwise worsen the toxicity. As we go through with the responses at the end of 3 cycles, when full doses have been given, we see responses which are similar to what is reported in the literature, which is at about approximately 50% of the patients, of which half of them would be complete responses. Now, whether exposing them to so much toxicity and losing them early will actually increase responses in the remaining is something which is hard to say and will be difficult to prove also, because you don't want very severe reactions in these patients.
But do you need to give obinutuzumab for every cycle, or
no? It is the first priming on day 1. After that, when we start, it is day 1, day 8, day 15 of step-up doses of the bite, and then we give it only once every 3 weekly. So glofitamab we give IV, and the other one, mosunetuzumab, we give it as a subcutaneous. Subcutaneous, I think, adds on, because there you don't need the priming. And by giving subcutaneous, I think the toxicity by itself is mitigated. And so that is the double advantage of mosunetuzumab.
Okay. Another question I had was, is there a difference in the response for the bispecifics to DLBCL versus the high-grade lymphoma, NOS, double hits? Is there a difference in the response among the different categories?
The most of the trials are still early, which I showed you. They are phase 1, 2. Most of the patients are relapsed refractory DLBCLs. There's not much information available on the other high-grade lymphomas, which is a category which is being more and more described now. But if we look at the meta-analysis, then there is something to suggest that if you look at the differential outcomes, the outcomes with CAR may be better than BiTEs. So definitely there will be, as we see more aggressive lymphomas, we may find that the CARs work better for them than the BiTEs.
Yeah. Just a last question. Can we use this bispecific as a bridge to transplant instead of salvage chemotherapy?
We do that. So 3 cycles, and only thing is you have to be a little careful of the transplant after that, and delay the transplant slightly. And we haven't done any allogenic after that.
But do you need to collect the stem cells prior to it, or we can do the collection later after the bispecifics?
So the only patient that we have, we've done it after.
Okay. Okay. Thank you so much.
Thank you, sir. Dr. Ramesh, your question, please.
Good morning, ma'am. That was a wonderful talk. I have 2 questions. Considering the cost and the logistic issues, do you have any preferred salvage chemo for these patients, and what is your take on allogenic transplant in these patients? Because in Hodgkin, relapsed refractory Hodgkin, we have seen very good responses with bendamustine and lenalidomide. We have 2 patients who are refracted after allogenic autologous transplant, and after that we gave bendamustine and lenalidomide. They went into CR. And we have allogenic transplant has been done. It's 2 years down the line, they're doing good. Like for any your preference for any salvage chemo in DLBCL relapsed setting?
So, I showed you our general treatment is the way I showed you for this particular patient. We will go ahead with the first line of salvage therapy, and we will do a high-dose chemotherapy if they're in good remission and an auto transplant. If they relapse again, we try another salvage line, which is generally a gemcite-based protocol or some change in the therapy. If it is Hodgkin's, of course, bendamustine, brentuximab is a great bridge to the next therapy. If they've already received brentuximab, we consider them for brentuximab with nivo, and that also puts a lot of resistant patients into response, and then we've taken them for allogenic transplant. And just as you are saying, they're doing extremely well. But this is not true with diffuse large B-cell lymphomas. It is a much more harder disease to manage. So with the first line salvage patients, especially patients who have relapsed more than a year later, they seem to do reasonably well with the salvage therapy, and you can take them for auto transplants. For those who are refractory or relapse within a year, they are the ones who are more resistant to these kind of salvage therapies. And I think those are the patients in whom we need to now start thinking differently. If CARs are available, of course, that has become the standard of care, and that is the NCCN recommendation as first line salvage for early relapses in DLBCL. The funny thing is, like you said, we have given glofitamab, the patient has progressed, and this is a primary progression of a patient of DLBCL on R-CHOP, followed by we gave lenalidomide for some time because we need 3 lines of therapy before we can get glofitamab. And then we gave another line of therapy, and then eventually, and it was all resistant to glofitamab. Along with Gemox. And now I have put her on something like Pepsi, and she seems to be responding. So in DLBCL, never say die, that's all. So any regimen that works for a patient, you can use it.
Okay, thank you.
Thank you, Dr. Ramesh. Dr. Narendra Chaudhary, your question, please.
Yeah, thank you for very nice and informative lecture. As we know that Blina has been used in relapse B-cell ALL with good response and bridging therapy before transplant also in children. So because being a pediatric hemato-oncologist, I just wanted to know any experience of Blina or other bispecifics in DLBCL pediatric patients.
Okay, so the disclaimer will be I don't treat pediatric patients, but I know.
Yeah, in your age criteria also, I think 36 year was the lowest age.
Mine is strictly over 18 years. I think very, what should I say, soft-hearted people should treat pediatric patients. But our team in the pediatric group uses a lot of Blina and ALL. They have a reasonably good experience with it, and they, of course, take care of their patients quite well. Blina has this problem of a lot of ICANS and CRS and grade 3 and 4 also. So one has to be really careful. We have given Blina only to 2 patients of ALL, I think. The entire thing is, it is very cumbersome, having to keep the patient in the ward continuous 24-hour drips, and then having a high incidence of ICANS and CRS kind of has now given us the confidence that with other bites, which are much easier to handle, and some of them outpatient, we are able to take care. So we kind of moved away very quickly from Blina, which we used in the very initial time. And then for lymphomas, at least, we have kind of completely moved away, and we use these other bites, CD3 and CD20.
Thank you.
Thank you, Dr. Narendra Chaudhary. Dr. Yimontet has a question. She has put in the chat box. And her question is that what is the factors which should be considered in priority to choose CAR-T versus bispecific antibodies?
So, so far it has always been availability. Let's say cost out. It has always been availability. The speed with which the CARs can be prepared, especially in a patient who has aggressive disease and is progressing rapidly. Sometimes the CARs don't come in time and you lose the patients. And so these were the advantages of bites, that it is off shelf, you can get it immediately, you can start quickly, and you can start slowly so that you can reduce the toxicities. And nobody really knew which one was better. So just while I was preparing for this lecture, I chanced upon the new paper which has come in this week, which actually has started giving us a little bit of directions. And so it appears that if CARs give better response rates, and especially if you are considering a double hit lymphoma, and if you can manage the ICANS and the CRS, you have a good team which is anyway used to transplants and managing, then I think at the moment, if I have to follow what is this evidence in literature, it will be CARs rather than the bites. At the moment, getting it for us takes about the same amount of time. From the time we start the paperwork to the time we get it, it's about a month. And that is not, short enough for many of the patients. So we have the same problems of bites not coming in time, like the CARs don't come in time.
Absolutely true, ma'am. There are no other questions in the chat box. Any discussion want to ask any other question? Fine. So there are no more recent science, ma'am, and no more questions from the audience. Well, thank you so much for that fantastic and lovely talk. As always, always good to listen to you. What a depth of knowledge you have, ma'am. Thank you so much for being with us as a guest speaker today. And I thank all the audiences as
limited
well.
knowledge. It's not depth, it's limited knowledge because I focus only on one area. So thank you very much.
Good to hear to you, ma'am. Thank you. I thank all the discussants as well as audience to join, and meet you next week with other beautiful webinars. Good day for now.